Third degree, or a complete heart block, occurs when the AV node fails to transmit any signals at all. Of the heart blocks that involve failure to transmit, i.e. the second and third degree heart blocks, third degree is by far the most common. However, its overall incidence remains relatively low. So a long-term review of people who had presented with both acute and non-acute problems of a cardiovascular nature indicated less than a 1% incidence of complete heart block. And the study also found out that most patients that have a heart block have some pre-existing heart disease. And for more than half the people that have a block, it was found to be a transitory problem, that is, that it sort of cured itself. But 50% of those who were found with a heart block did require some long-term treatment. More often than not, a pacemaker needed to be installed. Its association with acute injury is a lot more prevalent though. So of all the people that have an MI, somewhere between 2.5% and 5% are going to suffer some sort of complete heart block. We've traditionally associated the presence of a third degree block with worse outcomes. And while this is true, we should also keep an eye on the location and the size of the AMI. Now, this is especially true of occlusions of the left anterior descending artery, which has a far higher predictive value for worse outcomes than what the presence of a heart block itself does. Now, we know that some subsets appear at higher risk for poor outcomes, and a wide complex escape rhythm in the setting of an inferior AMI is a worrying combination. Third degree heart block caused during an anterior AMI, that is one that's more likely to be associated with the left anterior descending artery, are caused by damage to the distal or the lower part of the AV node. And this might extend down into the common bundle or even to the bundle branches themselves. It's indicative of widespread damage associated with the proximal occlusion of the left anterior descending artery, and the resulting pacemaker site is more likely to be ventricular. So for this reason, wide complex escape rhythms with rates less than 40 beats a minute are more likely to be associated with an anterior AMI. Conversely, occlusion of the right coronary artery is more likely to result in an inferior or posterior AMI, and this is expected to affect the proximal or the higher section of the AV nodal tissue. This allows for a junctional pacemaker to take over, and this is going to transmit through the distal section of the node and produce a narrow QRS complex. The rates we would expect to see here would range between 40 and 60 beats a minute. There are some other risk factors for developing a complete heart block. They include particularly type 2 diabetes, cardio-inflammatory conditions such as Lyme's disease, and there are some autoimmune diseases such as SLE that will cause lesions on the cardiac tissue that might result in one of these blocks forming. Management of third degree heart block is mostly symptomatic. That is, we're managing a bradycardia. In the acute setting, the concern is going to be related to the ventricular rate. As the AV node is not functioning, the ventricular rate is going to be determined by the location of the escape pacemaker. The site for these escape rhythms is likely to be junctional or ventricular, and in either case, rates of less than 50 are expected, and for ventricular rhythms, these can get down to 20 or 30 beats a minute. The prophylactic approach is recommended when wide QRS complexes are evident. Some studies have shown favorable outcomes when atropine is used in narrow complex escape rhythms, but overall adverse effects are shown to be higher when the block produces a significant bradycardia and hypotension. The recommendation for pre-hospital management, particularly in the setting of a wide QRS presentation, is to initiate transcutaneous pacing, so an early call for assistance and request for pacing is entirely appropriate when you see this rhythm. So then just this quick review for the characteristics of a third degree AV nodal block. So the rate, and we're thinking about the ventricular rate, is going to be mostly dependent on whether the escape rhythm is junctional, in which case we'd expect to see a rate between 40 and 60, or if it's ventricular, it may be between 20 and 40. In most likelihood, the R to R rhythm is going to be relatively regular. The P waves could be either sinus or atrial, but it's of no real concern because they're not going to correlate with the QRS. And we'll go through some of the clues as to how we might find this out shortly. One of those big clues is when we find P waves that are superimposed over the top of T waves or QRS complexes. While there is no true PRI to measure, an inconsistent relationship between the P waves and the QRSs is going to be one of our most significant clues that it's going to be a third degree block. And finally, when we look at the QRS, we know that proximal blocks are going to display narrow complex escape rhythms, while distal blocks, those that are associated with larger anterior AMIs, are quite likely to produce wide QRS escape rhythms. So let's see this in practice. The ECG we have here shows a regular rhythm that has a ventricular rate of 30. Finding all the P waves in this one can be a little bit tricky, but in this case, the peaked and biphasic nature of the P waves can be seen superimposed with T waves. When I measure them out, it looks like they're falling pretty regularly, so I'm quite happy with my assumption that they are in fact independent P waves. The atrial rate is 90. And so we already know that there are significantly more P waves than there are QRS complexes. So this has to be a second or a third degree heart block. But because the R to R interval is regular, we can discount a type 1 second degree heart block. So we're only left with two choices at this point. It's either got to be a second degree type 2 or a third degree block. The P waves that we can see are positive and rounded in lead 2, so we think it's sinus, but it's not really a big help in terms of interpretation for this rhythm. What will be helpful is the PRI, and again I can't stress how important it is to make sure you've measured a couple of sequential PRIs across the ECG to get an indication of whether they are all the same or not. In this strip, the PRIs are not consistent, and in fact, they appear to shorten as we read the ECG from left to right. The answer to the question about what sort of block it is lies in this knowledge. Firstly, a second degree type 2 block has a constant PRI, so we know that's not the answer. Secondly, there is no rhythm that displays a shortening PRI as we read it from left to right. The only conclusion, should you see this occurring, is that the atrial and the ventricular activity are in no way related to each other and that the rhythm is a third degree block. So let's look at one more example of a third degree heart block. Again, we can see we've got a relatively regular rhythm in terms of the QRS complexes. And while the R to R intervals are not exactly perfect, they're close enough to be representative of a regular rhythm. The ventricular rate is really slow. It's lurking between 20 and 30, so this is a significant bradycardia. Again, the P waves can be a little bit difficult to discern. One of the advantages we have when we're working with ECGs as opposed to a rhythm strip is that we can inspect several leads to help find these P waves. And in this case, we can see the P waves imposed over the T waves in some leads where it's not necessarily obvious in others. And we can use the vertical axis to correlate these findings with the rhythm strip. Now the atrial rate's around 60 a minute, so again we've got significantly more P waves and QRS complexes, so this has got to be either a second or a third degree heart block. The regularity of the R to R intervals excludes the type 1 second degree heart block, and again the answer is going to lie within the PR interval. As I read this strip from left to right, it would appear that the PRIs are getting shorter. As this does not occur in a natural rhythm, my assumption is that the atrial and the ventricular activity are entirely independent and that this is a third degree heart block. The other evidence I have for this being a third degree block is having seen the P waves superimposed onto the T waves. So that should that occur for either a QRS or a T wave, is another strong indicator that the atria and the ventricles are operating absolutely independently. Hope this has been useful. We'll have opportunity later on to practice our rhythm interpretation with these, but in the meantime, ka kite.